All right, next up we have Alan Kurose. Dr. Kurose. Dr. Kurose, you're on with the committee.
Hi, good evening. Thank you.
There, if you could let us know if you are testifying on behalf of any organizations, and then you can just go ahead with your testimony.
Okay, sure. This is Dr. Al Kurose. I'm the CEO at Coastal Medical. I was actually also a board director for the Quality Institute quite a few years ago now when the Current Care Health Information Exchange was first stood up. And I'm really appreciative of the opportunity to just offer a couple of perspectives. I think hindsight's always 20/20, and I think the intentions and the hard work were all appropriate at the time the original decisions were made, but I really feel now that the proposal to change to an opt-out model, its time has really come. I think it would be incredibly beneficial for the state. I was a practicing primary care doctor for 20 years, and I can tell you over those years, I saw more instances than I could count where the care of a patient was either made sort of wasteful at best and dangerous at worst when information was lacking at the point of care about a patient's medical history. So I think there's a huge value in terms of cost efficiency and patient safety. I'll also tell you from my position, being CEO at Coastal now for about a dozen years, that being able to access the kind of information that Current Care holds is hugely valuable in terms of making sure that preventive care is up to date, cancer screening, immunizations, and the like. It takes an awful lot of effort to track that kind of information down sometimes. Having it in Current Care is very inefficient. But knowing that half the time you look in Current Care, you're not going to find the patient you're looking for because only half of the population, or roughly half, is enrolled, that's a real drawback. And it adds to the cost of doing the work, and it lowers the yield. So I think that if you have half the population, you're getting a lot less than half the value. And I think that transitioning to an opt-out makes all the sense in the world.
Thank you, Doctor. I see that Senator Bell has a question. Go ahead, Senator Bell.
Thank you so much, Madam Chairwoman. Doctor, we had a number of questions earlier for members of the Quality Institute, and I know that you're not currently serving in that role, but you do have a lot of experience there. And I'm wondering if you might be able to answer some of these questions. So
sure.
One of the questions I had was, and I understand if this is not a question you can answer, but what assurances do we have that these data will not be used for alternative payment models? Another question I had was about the language in the bill that allows state agencies to obtain information with, as far as I can tell, no requirements of anonymity, basic data safety protocols, and whether that's intentional or whether those protections exist in place, I can't find. And then the third question I have is about ensuring privacy issues, and I think a related element is ensuring that patients are actually able to access their medical records, because sometimes the current systems don't actually allow enough access for patients. It can be difficult for patients to obtain and make sure that they own their own records. So are those questions that you can answer, those four questions?
So those were a lot. No, that's okay. Those were a lot of questions. I'll start maybe with the last one first, which is to reference I think it's called the 21st Century Cures Act, where federal government regulation is making it so that patients are entitled to a greater level of access to their own electronic health records than ever before. I think you probably have other witnesses who could give you more expert testimony on that, but I think that we're at a moment of change for the better in that arena. As far as the question about alternative payment models, I didn't quite understand that question, but it's one I might be able to answer because a lot of the work I do relates to alternative payment models. So if you could be more specific, I could try to help on that one.
Sure, and through the chairwoman, if I may, my question was, because this involves release of information to the state and to state agencies, I was concerned that actually some of the data involved here might be come involved in alternative payment methodologies. So my concern was that by allowing patient information to be released, we might be encouraging the use of alternative payment models such as capitation, episode-based payments, issues like that. And of course, we have had significant difficulties with meeting the APM quotas in actuality, and of course have had difficulties with the implementation of globalized capitation under the Medicaid program, the accountable entity program. So I'm just concerned that I want to just make sure that we're not going to be facilitating the use of these alternative payment models with the release of these data. And a previous speaker had mentioned the possibility of that. I just want to make sure that that's not happening. So that's really my question there. My other questions are about patient medical data confidentiality. But does that help clarify? Do you understand what I'm saying?
Maybe a little bit. I'll try to make a useful comment. You know, I think that the devil's in the details when it comes to alternative payment models. Some of them are actually very well designed to improve the quality of care, the service to patients, that hold provider entities accountable for outcomes. I think those are all good things. But there's a distinction to be drawn between the alternative payment models themselves and the method of care delivery. So what is commonly referred to as population health management is really where access to data like current care comes into play. Population health management is sometimes paid for using alternative payment models, but what it really describes is a proactive approach where providers take an accountability for the health of a population, and inherent in that is, and in that proactive approach, is that you're looking for data to make sure that patients have received the different types of care that they need specific to their medical conditions. And you do this whether they're sitting in front of you for an office visit or not. So having a data repository where you can query whether all of your diabetic patients are up to date, for instance, on routine diabetic testing, and where you can query the extent to which their blood sugar is or is not controlled. That's part of population health management more than it's part of specifically being related to any alternative payment model. And I would say having a data repository like current care makes population health management more effective, and I would say that population health management is in the public interest. The more of that we do, the healthier population we'll have. I'm sorry, there were a lot of questions there. I'm trying to think of some of the others that I might be able to comment usefully on. Maybe you could help me.
Yes, so thank you so much. That was a very helpful clarification. I think it helps me understand the way this would interface with APMs, which, you know, and just to be clear, I think that APMs should be more involved around the population health management. It's one of my criticisms of our existing APM programs. They have not actually involved efforts as much to improve population health. But they are sometimes integrated, such as, for instance, the risk-sharing provisions are for instance, even the accountable entity program are in fact tied. One of the quality metrics is A1C of diabetic patients. So I'll
divert really briefly, because this is what I do every day, and if there's anything I can help you on, it might be the vein that we're in right now, which is just to add a comment that a lot of these alternative payment models are based on the total cost of care. And the total cost of care is favorably influenced when you can be proactive in the delivery of care. So sometimes the connection between different types of population health management efforts and alternative payment models and cost efficiency might not be totally obvious on the face of it, but if you take patients, particularly like patients with congestive heart failure or COPD, and you manage them proactively, what you're doing is you're keeping them healthier, you're keeping them out of the emergency department in the hospital, and those are the big ticket items which, when you can influence the care of a population where they occur less often, that is what drives financial success under alternative payment models. So sometimes connecting the dots is not quite linear, but in the way that I look at the business underpinnings of population health management and alternative payment models, access to this kind of data set is crucial, because one of the things that current care also gives you is it gives you awareness of events that you really need to know about in the care of a patient. If they're hospitalized, if they're in the emergency department, you want to know that as soon as possible and be able to gather that data so that your team can reach out and make sure that those patients have appropriate follow-up.
But, thank you. That has been extremely clarifying and has really, it does seem like this could be utilized as part of even using a total cost of care methodology.
Exactly.
So, yeah. So thank you. That's been really helpful and really helps clarify the issue and helps me understand that is a real concern here. My other question was around simply the provisions that exist for patient privacy and privacy of medical information. And the specific area I was concerned was with the information released to state agencies, which do not seem to have any HIPAA protections or even anonymity protections written into the statute or the proposed statute. And that struck me as anomalous, and I was wondering, even it was so anomalous, wondering if I was actually misreading it, and it does exist somewhere. But the broader question was about how we can be sure that patient medical information and confidentiality is protected, and the patient's rights and desires to sometimes keep information private. Sometimes and there are often very valid reasons to that, where our patients might not want information shared with their doctors. For instance, we often have stigma around mental health, and some patients really believe strongly that they want to keep their mental health records private, things like that. So what assurances do we have there?
So I shouldn't comment on the access of state agencies to patient health information. I'm not knowledgeable on that topic. As I understand the proposed legislation, it does include inherent in it is that for certain types of behavioral health information, consent would still have to be given to share it. So, and I think that was the original intent when the opt-in model was chosen first, was that you'd thereby have you'd have that ability to share behavioral health related information right up front. I think the price that we paid for that by sort of constraining enrollment, just because enrollment is such a labor-intensive process, that trade-off turned out not to be worth it. But I think for sensitive behavioral health information, a more active form of consent is still required. With respect to our access to health information in current care, the same sort of legitimate need to know stipulations in the delivery of health care apply. So we don't, from our perspective as a primary care-driven ACO, we don't see a difference in this model, and because we're still held to the same HIPAA standards. I will tell you, as somebody who practiced primary care for 20 years, and now I've been leading an organization that takes care of 120,000 patients, and basically whenever there's a HIPAA violation or a privacy breach, I'm made aware of it. For every one time that there was a data breach, a violation of somebody's privacy. I think that I have seen literally hundreds of instances where care was compromised at the point of care because of a lack of access to full clinical information. So I totally respect and understand the privacy needs of patients, and I don't mean to diminish that, but I would convey that at least in my real-world experience, and it was individually as a provider, but it's as a practicing physician, but as the leader of a provider group, it's extensive and lengthy now. It's really the well-being of patients at the point of care that really dominates the considerations here, as far as I'm concerned.
Thank you so much.
Thank you. Senator Bell, I believe our committee attorney has some comments, maybe able to address some of your concerns, so we're going to let him go ahead and make some comments right now.
Right. So, Senator Bell, each provider that participates in the Quality Institute's Health Information Exchange can only release the information if it's permitted to do so by HIPAA, and the exchange either is a clearinghouse, which is a covered entity by HIPAA, or a business associate of the providers that give information to the exchange, and as a business associate, they have to comply with HIPAA in the same way they would if they were a provider or a covered entity. And in their permitted releases to the government, once again, they can only release to the government if it's permitted by HIPAA. So there doesn't really need to be any affirmative language in the bill that you're considering to address privacy concerns if you feel that HIPAA provides adequate protection in terms of releasing information to the government. And what I would say is that HIPAA only permits information to be released to the government in a de-identified form or for purposes of public health activities or law enforcement.
So thank you so much, Mr. Weinberg, I believe it is.
Mm-hmm.
This is, I think, probably a longer conversation, and I don't want to, delay the committee process with this. Would it be possible for you to follow up with me over the phone to have a more in-depth conversation about the legal specifics on this issue?
Yeah, sure, anytime.
Absolutely. If we can make that happen, that would be great. And I'll place my phone number in the chat, or perhaps Vice Chair Valverde can just give you my phone number so you can give me a call.
Great. Thank you. All right. And are there any other questions from the committee for Dr. Kurose? All right. I don't believe so. All right. Thank you so much for calling in, Doctor.
Appreciate the opportunity. Thank you.
So thank you again, Senator Valverde, for assisting tonight. The next call we're going to try to connect with is Heather Burback. Heather, you're on with Health and Human Services. Go right ahead. Heather represents the Rhode Island ACLU and is speaking on behalf to let us know which bills you're commenting on as you do so. Thank you.
I will. Thank you to my Senator, Chairman Miller. I'm here tonight, as you said, on behalf of the Rhode Island ACLU. I am speaking tonight on 3 bills, and I will address them in numerical order, but to give you the numbers from the top. It's bills numbers S62, S495, and S713. The first one, I'm proud to say that the ACLU is in the position of being able to support. That we feel very strongly that what happens between a doctor and a patient should be between a doctor and a patient. And these explanations of benefits, you've heard a bit tonight already, and so I don't want to rehash what's already been said. But that the fear of other people getting the information frequently will cause people to not seek care, and that is a problem. And or other people actually getting the information and the backlash that causes afterward. You heard information earlier this evening about college students and the fear of getting different types of care because they don't want their parents to find out. That doesn't just apply to college students. It applies to adolescents who are under 18 who want to go, that are covered on their insurance plans and want to go to their doctor for STD testing or for other sensitive topics and don't want the information disclosed to their parents. That is an issue between the patient and the doctor about whether or not things get disclosed to the parents. And it shouldn't be the insurance company afterwards deciding to disclose things to the parents on these explanation of benefits forms. Additionally, domestic violence is a huge issue with the sending of these forms to just policy providers. That sometimes people are actually in hiding from their abuser, but their abuser is the one that has the insurance policy. And so these explanation of benefits forms have been the cause of abusers finding out where somebody is and doing everything in their power to track them down and find them. This is not a hyperbole situation. This is an actual case that I dealt with in the past month and a half, that this happened to a young girl. In her case, the abuser was her father, and she was still on her father's insurance, and the insurance sent a letter to dad when she sought some medical care. Additionally, there's a lot of reasons why somebody might not want someone else to have their medical information, and it deters people from getting the health care that they need. Having a deliberative method for sending summaries and a way to figure out where things should go is the right way to do this, and it's the right way to make sure that patient care is patient care and that the information isn't being disclosed to other people. We think that this bill will not only protect individuals, but will help promote public health. And so we strongly urge the passage of Senate Bill 62 and its companion in the House, and we appreciate that bill coming forward. Moving on to Chairman, would you like me to move directly on to the next bill, or do you want me to pause for questions on each bill?
I'll ask if there's any questions on that testimony for that legislation. How's that?
Okay.
Any questions on the testimony on 62? If not, go right ahead.
All right. Moving on to Senate Bill 495, we are, for similar reasons, opposed to this bill. And this is the bill that you've heard a lot of testimony about this evening, about the opt-in or opt-out of the state health information exchange. And we're opposed to that for the same reasons, that what happens between a doctor and a patient should be between a doctor and a patient. If the doctor believes that having the access that you've heard about tonight to this information is important and that they really want their patient involved in this exchange, then the doctor can talk to the patient about making sure that that happens. That the vast majority of patients who opt out, if they then have a discussion with their doctor about it, the doctor is able to talk to them, and then as opposed to the 50% that you've heard about tonight, the numbers go way up to 83% once they've had a chance to talk to their doctors. We don't want to take away the right of the doctors to talk to them about being part of this exchange, but we want it to be the patient's decision, and we want the patient, the individual, to affirmatively consent to waiving their privacy rights, as opposed to having to figure out that they're actually waiving a bunch of privacy rights and figure out a way then to opt out of that system. Our position on this bill shouldn't be any surprise to anyone. We have been bringing this information and opposing this becoming an opt-out system for over a decade now, as each time it's been brought up to try and have people opt out of the system. There are a lot of reasons why people don't want their information shared through others, including just in a database. They might fear the possibility of a data breach, even if it's not a realistic fear. That's their information to decide what happens with, and if they don't feel comfortable, that's, again, a conversation between them and the doctor, but it ultimately should be their decision. They may also have strong concerns about the fact that the HIE doesn't allow for patients to limit or control what types of information do and don't go in there, and they can't have any control over their data once they're in that system. And there's serious questions about can they get the data out of the system if they later decide that they don't want to be part of it. And we want the patients to have these decisions. We don't want it to be part of an automatic process. What we've heard throughout the evening with the testimony is we need the data, and we haven't heard about we need the patients to feel comfortable and trusted, and we need to protect people's privacy and their rights. In the testimony that you've had, I know some senators have brought up the issue, but that's really what it comes down to, is that patients get to decide who gets their data and who has what information, and we want to have that happen. There's an interplay between this and the other bill that I just testified on, which is that sometimes errors happen, and things get put in the wrong place, and people should be able to have more control over their data and their information. That when we respect privacy, it's important. A lot of this, why not just opt into, have it opt out, is a little bit akin to the argument of, well, if you don't have anything to hide, why not consent to a search? The police would tell you that it's much easier for them to stop all the crime if they can just go door to door and walk into anybody's house and do whatever they want whenever. But we value privacy, and in this instance, we should value the patient's privacy here, too, to decide what happens with their information. And it's not a matter of they have to affirmatively ask the police to step out. It's a matter of, no, the police have to get permission to come in. And in this instance, we want the data to be given permission to go into this exchange, as opposed to it just goes in unless you do something to affirmatively stop it. So that's why we would oppose this bill and believe that it should remain an opt-in provision as opposed to an opt-out.
Senator Bell has a question for you on that bill.
Thank you so much, Mr. Chairman, and thank you so much for your testimony. One thing that you mentioned in your testimony really stuck with me, which is that there aren't limitations on the types of data. One of the concerns that I hadn't really noticed that and assumed that there would be more limitations there, but going back through the bill, it does seem correct, and at least initially scanning. I'm really concerned about the possibility of medical information with law enforcement implications, especially now that state agencies, which I believe would include the state police, and there was previous mention that law enforcement might be able to gain access to some of these data, might be able to access information that has law enforcement. So I'm thinking specifically about illicit drug use, and many drugs are currently illegal to use, and often it's really important in a medical context that patients feel safe to share that information with their doctors, with an understanding that that information cannot get shared with law enforcement authorities. And this question is routinely asked about cannabis, which hopefully, thanks to the chairman's years of work, we will be legalizing in this state. But there are many other drugs that will remain illegal, and it can often be very relevant to medical care. So is your read of this bill that it could involve essentially having the sharing of information that includes illicit drug use, and that the access to state agencies might allow the state police to access medical records that contain records of illicit drug use, including, because the language would presumably include records that already exist, allowing the state police to access existing records of Rhode Islanders who have shared that they use illicit drugs with their medical providers?
So I would partially defer with regard to that question back to the statements that were just made by Legislative Counsel a few minutes ago about disaggregation of data and HIPAA protections on things. I'm not sure what the law enforcement can and can't have access to at this point, but I don't think it is a far reach to presume that at some point they might ask to have access to this because of, trying to prevent overdoses or other things, and then we've opened up a large can of worms. what we've seen with all these large databases for different things is that once they're created, everybody wants access to them. And trying to stop people from getting access to them becomes very hard because everybody thinks of the immediate, altruistic purpose that somebody might want the data. And it's harder to come back and you say, yeah, but it could also be used for this and this and this. And everybody says, oh, nobody would ever do that. And then somebody immediately starts doing that. I think back to some experiences my husband had when he was in grad school and teaching some classes. And students would come up with proposals for, we're going to create this new automatic thing that does this and this and this. And he immediately would say, wait, but couldn't it also do this, 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 and this? That would be super bad. And it would be, the response would be, oh, we couldn't imagine somebody would do that. And so the example or the possibility that you bring up, Senator Bell, I think is not far-fetched and not unrealistic, that even if the law currently doesn't allow it, and I would defer a little bit to Legislative Counsel with regard to whether or not it could currently allow it. It's a very, very thin wall that would disallow it at this point. And I would give another, and this is anecdotal. This is, anecdotes aren't data; they are stories. But I can tell you from personal experience, having a close friend that did have a drug and alcohol substance abuse problem. And they were out of town and went to a doctor because they were having some complications from a secondary issue that they had. And they went there and they disclosed to this doctor that they have this substance abuse issue. And the doctor said to them, well, it's good that you're just here from out of town because I would never treat you again now that I know that you use these illegal drugs. And if that's now in something like an HIE, Health Information Exchange System, what other doctors are going to refuse to treat this person because of that sensitive information that's in there? And this is without getting into any of the hacking or breaches of databases or anything else. This is just for things being used the way that they were intended and the potential poor consequences thereof. So that's a long-winded answer to your very direct question. I apologize.
Thank you. Very helpful answer. Thank you so much for your testimony.
Yeah, I would just comment, the few years I've been here, I know that ACLU has respected and actually complimented when the HIPAA status was used as a way to control the disbursement of data. So I just want to put that in context too, is that HIPAA is used as a standard also by the ACLU in many cases as a way to limit the spread of data and patient information. And as I understand it, also based on the years I've been here, that that law enforcement access is very limited. To use the prescription database as an example, the only information law enforcement can access is information that has to do with physician prescription towards repetitive description through a diverse amount of prescribers, and it's used to identify those who are over-prescribing or a patient that is accessing the same drug intentionally through several physicians. And the type of data they're allowed to access is very restricted, and I think and we can check before we go further with any legislation, including this, that that this legislation would be as consistent as that legislation is to law enforcement access.
So I appreciate your comments, and I don't disagree. I would also note, however, that there's been a lot of bills to try and expand law enforcement access to that prescription database, and the ACLU's been at the forefront of fighting pretty hard to try and stop further law enforcement access to that database.
You want to move on to the next bill?
Absolutely, absolutely. The next bill, and actually this dovetails quite nicely, is Bill S-713, dealing with the medical examiner's office and the team that is brought together for certain examinations. When this bill was brought in 2018, our office had serious concerns about the inclusion of law enforcement on the teams that were being brought in. And at the time we came up with some amendment language. We've submitted written testimony that includes the amendment language that we would suggest for this bill. That the amendments that we suggested back then and were told at the time that Department of Health was on board with our potential amended language, which is essentially to keep law enforcement from being on the team, or to the extent that they need to be on the team because they have particularized knowledge of a location or a set of circumstances, to make it clear that the information that's gained from this team isn't used for specific enforcement purposes. That basically we understand that for overdose deaths, we want to try and prevent them. However, this team is, as was stated earlier tonight, not meant to create, tracking down people by what's done in the autopsy or other things through this team's work. And so we're suggesting that if the sunset provision, which was the compromise because we simply ran out of time in 2018 to get the amended language in, we ran up against the end of a session issue by the time we got language drafted and ready to go. So the compromise was a sunset provision. The sunset provision is now up, and we suggest that this compromise language would be a good way to do it, to eliminate the concerns about law enforcement improperly using specific data gained from it. You know, what we've learned from passage of things like the Good Samaritan Act is that it's okay to have law enforcement involved in the process as long as we have some safeguards for exactly how it's going to be used. And so it dovetails with what we were talking about with the prior bill. And so if that amendment was made, we would be in support of the legislation. As it stands, we would oppose it.
Have you received any information since it was enacted that would lead you to believe that that amendment is still necessary?
I think that the question could be asked in reverse, which is, if the amendment isn't if they're not using it for that purpose, why not have the amendment just so that we keep everybody on the same page?
Your written testimony includes the amendment?
Yes.
Okay.
That it's a fairly small amendment. I can read you the language if you'd like, but I know that it's already distributed and you're pressed for time.
Yeah, we can reference it. We still have many people to get to.
Yes.
Any other questions for Heather? Thank you for calling in.
Thank you for your time.
Yep. The next person we're going to try to connect with is Dr. Mark Ryan. Mark Ryan, Dr. Ryan, just identify if you're representing somebody else and which bill you're testifying on.
Thank you very much. Good evening. My name is Mark Ryan, and I'm a physician practicing internal medicine in Rhode Island for the past 30 years. I am also the current chair of the Rhode Island branch of Physicians for a National Health Program, a national organization of more than 20,000 physicians advocating for a single-payer Medicare for All universal health insurance system. I'm speaking tonight in favor of Senate Bill 379. I thank Senator Tiara Mack and all the other sponsors of the bill and this committee for providing an opportunity to testify. The funding of our healthcare system, both in Rhode Island and nationally, is unstable and unsustainable. It's estimated that one of every $3 funneled into our system is never used to pay for healthcare, but instead is spent on the highest drug prices in the world and massive administrative costs generated by private insurance companies. Medicaid is a safety net program for those too poor to afford private health insurance who work for employers like Walmart that have figured out how not to pay for their employees' health care, and for seasonal workers who only have funds to pay for expensive health insurance part of the year. Medicaid is also an extremely expensive program. In recent years, Governor Raimondo, in an effort to try to trim the percentage of the state budget consumed by Medicaid, made the decision to cut its funding twice. This resulted in, among other things, the closure of Pawtucket Memorial Hospital, which was situated in a town that contained a large number of people who were either Medicaid insured or who had no insurance at all. The problem with this is that those patients did not go away, but instead are now seeking their care at other hospitals, most particularly Miriam Hospital and Rhode Island Hospital. As a result, we really have a strong interest in making sure that our Medicaid program remains solvent and is able to effectively pay for the care that our healthcare providers are providing to our fellow citizens. It's difficult to know what is actually happening with the system when the management of that system is awarded to private health insurance companies, which is what managed care organizations essentially are. They're private companies that are being given government money to administer a government program. The reasons for this, theoretically, are that they will do a more efficient job. The problem is we have no evidence at all that that, in fact, is what is happening. Insurance companies typically have a 15 to 18% internal overhead, which compares to national Medicare, which has about a 3% overhead, and state-run Medicaid programs, which have about an 8% overhead. How companies that cannot run their own private insurance efficiently can do a better job running a Medicaid program efficiently is unclear. We have heard knowledgeable people tell us that, in fact, Medicaid does audit its own program, and yet somehow that auditing failed to uncover a $200 million overpayment by the state to private insurance companies in 2015, an amount that had to be paid back. Medicaid is not as well funded. It also doesn't reimburse as well as it might. Nationally, we find that Medicaid recipients, whether they're MCOs or not, have more difficulty getting into physicians' offices than people with private insurance. So the system clearly needs to be evaluated. Given the amount of money we're giving these managed care organizations, given the fact that they are being run by companies that we already know are inefficient and that have no interest in doing their own self-auditing, that $200 million overpayment was uncovered not by the private companies that do Medicaid.
Dr. Ryan?
Yes, sir.
In the effort to try to get to the still at least a couple of dozen people that have signed up to testify, if you could paraphrase and the written testimony, if you are reading it from it, just make sure we have it.
Yeah, no, I don't have it at the moment.
Okay.
Believe it or not, sort of making it as I go along. In any case, I appreciate the time constraints. So I just want to say that the evidence that we have available would indicate that the MCOs are not doing a very good job efficiently administering Medicaid, and it makes sense, therefore, for the state to actually take a long, hard look at the job that they are doing and try to figure out if we're getting the best value for the money. Thank you very much for giving me the opportunity to speak.
Any questions for Dr. Ryan? Thank you for calling in.
Thank you.
I believe we have Jack Rustley on the phone.
Yes, I am here. Can you hear me?
Go right ahead. Yes, we can hear you. Just let us know which bill and if you're speaking on behalf of an organization.
Oh, okay, great. Yeah, so I'm speaking about Senate Bill 62, and I'm speaking for myself, but also on behalf of the Rhode Island Health and Privacy Alliance.
Go right ahead.
Okay, I just want to say thank you, Chairman Miller, and thanks to Senator Golden for proposing this important bill, and for the folks who co-sponsored it, and the committee members for taking the time to hear my testimony. I am a physician. I take care of young people in a primary care clinic here in Providence. And I just wanted to speak a little bit about my experience, because I think some of my colleagues that you'll hear tonight are going to talk more specifically about the bill and the details of it. So just to mention that our coalition is in support of this bill. We really hope that this committee votes it out of committee and it gets passed this year. So we're excited to support it this year again. So I just wanted to talk for a minute about why I think this bill is so important as a physician. Basically, the bottom line is, from research, my experience, and from the AMA, the Society of Adolescent Health and Medicine, the AAP, and basically any other professional organization in healthcare that's looked at this issue, is that when people don't feel that their privacy is being protected, they're not going to seek out the services that they need. I think we've heard that with some other bills tonight. So in this case, communications to policyholders in the form of EOBs can violate those privacy rights. And, for me personally, this has come up multiple times in my practice. I'll just share one brief story, and that is about a 19-year-old young woman that I took care of recently. So she came into my clinic and, disclosed a lot of real serious mental health challenges that she was having. And in talking with her, she was really hoping to see a therapist and even start a medication. But she was really concerned about her family finding out about the issues that she was having. In her family, for a variety of reasons, mental health issues are seen as a weakness, as a moral failing, and there's just a lot of stigma around her in that way. So she really felt like she could not talk to her parents, and even if they found out that she was pursuing care, that they would be very angry and that it would cause a lot of problems. So, I offered to refer her to a therapist to start her on medication, and she declined. And then I did talk to her about this issue of her insurance being in the name of her father, and then they would get a letter in the mail saying that, that they saw me, that they would see that she had seen a therapist or that she had pursued psychiatry care. And that was really concerning to her. I haven't seen that patient back again. I've reached out to her multiple times. I'm pretty sure that she hasn't connected with mental health care based on my conversations with her. And so I think this just speaks to how serious and real this issue is for patients and for providers. It's a really difficult position for me to be in, but it's also an extremely difficult position for patients to be in, like this young woman, really putting her in an impossible choice to choose between her own health and causing significant problems in her family. So I just wanted to leave it there, and I'm happy to answer questions, but thank you for your time, and on behalf of the Alliance and the folks that we are included, and that'll be in my written testimony that I'll submit as a list of everyone in the Alliance. But I think folks in the committee probably know that it's a pretty broad group of people and organizations in the state. So thank you for your time, and I'm happy to take any questions.
Any questions for Dr. Russley? Thank you for calling in.
Thank you. Thank you very much.
And I want to mention before we get to our next caller that if people have also submitted written testimony, to please reference that written testimony and paraphrase for the sake of getting through all the callers that are interested in testifying. So next we'll go to Jacqueline Goldman. Jacqueline?
Yes, hello.
You're on with the committee. Just let us know if you're representing yourself or other entities and what bill you wish to testify on, or bills.
Absolutely. My name is Jacqueline Goldman. I'm here representing myself, and I'm here testifying on S379, the audit and deprivatization of Medicaid managed care organizations. So, the state has been slashing the budget year after year, and especially now that the state is providing so much care and so many things during the pandemic, finances are tight. They've always been tight. So, why not have this easy way to save hundreds of millions of dollars a year by auditing and deprivatizing managed care organizations? I know that there was a bill that we talked about earlier tonight. People talked about how Connecticut did it, and then now we should do it. This is another one of those examples. Connecticut Connecticut got rid of MCOs, and they saved hundreds of millions of dollars, and this is something we could do. Frankly, we don't actually know quite how much money we would be able to save from this, and this is why we need the audit followed by the deprivatization. I know that there were reports that went, from the Auditor General, and were supposed to be looked over by the Joint Committee of Legislative Services, and, we recently found out that they didn't meet for 10 years, which means that we frankly don't know how much these MCOs are costing us, and there's no one really looking at any of this information. So the bottom line is, we have a lot of, we know that these are costing us a lot of extra money. If they weren't costing us a lot of extra money, you'd have people from those MCOs telling us how much money they're saving the state, but they aren't here and they can't show that. And so we really need to be able to understand the extent of this problem so that we can address it and make sure that we can have this money for the state budget so that we can address all of the other really important things that the state needs to do to take care of its people. So that's really it. That's why I support S379.
Any questions for Ms. Goldman from the committee? Thank you for calling in.
Thank you.
The next person we'll try to connect with is John Wesley. Mr. Wesley?
Hi, yes, this is John Wesley.
Go right ahead with your testimony. Let us know who you might be affiliated with and what bill or bills you're testifying on.
Sure. Thank you very much, Chairman Miller and members of the committee. I'm John Wesley. I'm the Director of Policy at the Rhode Island Coalition Against Domestic Violence, and I'm here testifying in strong support of Senate Bill 62. We are in very strong support of Senate Bill 62, sponsored by Senator Golden, and thank you, Chair, for your strong support of this bill as well. Senate Bill 62 is critical for the constituency of domestic violence survivors that we work with in Rhode Island. Every year in Rhode Island, we work with thousands of domestic violence victims through our shelters and member agencies throughout the state of Rhode Island. Last year, during 2020, we served, through our member agency programs, over 9,000 survivors of abuse and their children, and our statewide Victims of Crime helpline answered over 17,600 helpline calls, and we saw those helpline calls surge and spike during the initial months of the pandemic and the months immediately following the pandemic during the 2020 year. Senate Bill 62 is critical for survivors of domestic violence because we know that victims of domestic violence suffer from health consequences related to abuse at a high rate and suffer from abuse and the consequences that can be long-lasting consequences, including mental health consequences, with physical, medical needs, including treatment for broken bones or other injuries, traumatic brain injury, depression, PTSD, and pregnancy complications. All of these health or mental health consequences lead to an increased need for survivors to seek medical and mental health services without worrying about their private health information being disclosed, especially to an abusive family member or abusive partner. When an abuser is the policyholder on their health insurance plan, the victim may forego and or not go altogether to seek the services that she needs, including mental health services or medical services, due to fear that the abusive party may discover the services she's seeking through an ELB or other insurance communication sent home. Abusers often feel a lack of control if they find out the victim is seeking medical help or therapy, and they may be concerned that others will find out about the abuse. So which could potentially escalate the abuse and the violence, which we've seen firsthand by working with victims and by speaking to the advocates throughout the state who've worked directly with survivors and have told us of these experiences and this chilling effect that this can have with abuse victims. It's also affected victims with their family court situation if there's custody pending after an abusive situation or a divorce, where the abusive party has used EOBs or documents from insurance to use against the client when they find out they're seeking treatment or therapy for depression or other mental health services after, as a result of trauma and abuse. So it's further re-victimizing the survivor when this disclosure of services is made to the abusive party. So in closing, we know breaches in patient confidentiality can occur right now through breaches through EOBs and other insurance communications. This bill is a common sense solution to make sure that victims and survivors can direct health insurance companies to send the health information, their own private personal health information, directly where it should go to the patient at a designated address or alternate number or secure email. So we'd urge passage of this bill immediately this session out of the committee to the Senate floor. We really appreciate your support in the committee and the work you've done on this bill over the years, and we would urge strong support for this legislation. Thank you very much.
Any questions for Wesley? Mr. Wesley? From the committee? Thank you for calling in.
Thank you very much.
Yeah. We'll next try to connect with Julius Ferraro. Julius?
Hi.
Yeah, before you testify, could you just let us know whether you're speaking on an entity or organization and which legislation you're speaking on also?
Yes, I'm speaking in support of Senate Bill 379, and I'm speaking for myself.
Go right ahead.
Great. Yeah, I'm calling as a citizen of Rhode Island. My name is Julius Ferraro. In Rhode Island, in 2019, 450,000 people were underinsured. That's 45% of Rhode Islanders rationing their own health care because they fear health care costs, because their health care isn't good enough. 2019 was obviously before the pandemic, so those are numbers from before the mass unemployment, mass sickness, and mass death caused by COVID-19. We don't know what those numbers are now, so I want to thank the committee for hearing this bill. Our healthcare system is in crisis, and one small thing we can do to improve healthcare in Rhode Island is to get rid of the MCOs, which stand between Medicaid patients and their actual healthcare providers. So I strongly encourage the member of this committee to vote in favor of S379 and in favor of the citizens of Rhode Island. I understand that some members of the committee might be a little hesitant to sign on to a bill which commits to removing the MCOs. So there was a bill heard on March 4th which would only audit the companies and had no such commitment. And at the time, I just wanted to check in, Senator Miller, you said you were holding that bill and a few others to improve it so you could reintroduce it in committee. So I just wanted to find out what is the status of S49.
We're still working on all our legislation right now. It's not, the status hasn't changed, and that it still is a bill we're interested in, and therefore we're working on it.
Okay, great. Thank you.
Anything else?
No, that's all from me.
Okay, great. Questions from the committee? Thank you for calling in.
Thank you.
Next person we're going to connect with for call-in testimony is Kirk Robinson. Mr. Robinson?
Yeah, that's me.
Just, you're on with the committee. Just let us know which bill or bills you're testifying on and whether you're speaking for yourself or another organization.
Yeah, totally. Yeah, my name's Kirk Robinson. I'm speaking for myself, and I'm testifying in support of maybe Senate Bill 379. I'll be brief. So, this sounds like this act would require the Auditor General to audit Medicaid programs administered by MCOs, and would potentially end privatization management of Medicaid. I think it's a great idea to audit to conduct these audits. My understanding is that these MCOs oftentimes are administered, they're kind of like these black boxes, and I just tend to think that when we're doing Medicaid programs that are administered, that it would be good to have some degree of sort of public accountability for them. And, you know, I mean, I would also say, too, you know, I personally want to see the end of privatized management of Medicaid. You know, Medicaid is a public good. Healthcare is a public good. I don't think that there should be any profit incentives for things that people depend on for their livelihoods. I mean, you could ask me the same question about housing or schooling, and anything that's privatized in those areas I would also disagree with because they're public goods. So, yeah, so that's kind of what I've got for 379. I think that you know, the committee should really carefully consider this. It would be wonderful if it could pass out of committee and the Senate would have a chance to weigh in and vote on it. Yeah, I think that's it.
Any questions for Mr. Robinson? Thank you for calling in.
Thanks.
I believe the next call is from Linda Eibel. Linda?
Hello?
Yes, you're on with the committee. Just let us know before you testify which bill or bills and whether you represent an organization or are speaking on behalf of yourself.
My name is Linda Eibel. I'm testifying as an individual in support of Senate Bill 379, which proposes an audit of the Medicaid managed care organizations. I'm a Providence resident and a family practice nurse practitioner that has to deal with Medicaid managed care organizations on a daily basis. As a primary health care provider, we spend countless hours on the phone trying to get needed medicines and tests covered. We know full well that the default for many insurers, especially MCOs, is to deny coverage and then make it very cumbersome and convoluted to appeal their decision so that we give up. I do not believe it's coincidental that by far the worst offender of this is the one for-profit managed care organization in the state. MCOs are paid per member per month, and so it is completely in their best interest to spend as little as possible for actual health care. And yet, while allegedly trying to save money, the system is also inherently wasteful. One example is a recent patient who was diagnosed with diabetes a few months ago. She picked up a glucometer and test strips, which were covered by her MCO. Last month, she went to refill the test strips and was told they were not covered. She now had a new MCO, a different one, which covered only a different brand of glucometer and test strips. So her 6-month-old machine is now useless and she needs to get a new one. This is silly and wasteful, but happens all the time. In addition to the added and unnecessary red tape for patients and providers, MCOs cost the state nearly 10% of its annual Medicaid budget just in administrative fees and taxes, which adds up to over $2 million, not a penny of which goes to actual health care. I realize this is a small fraction of a multi-billion-dollar budget, but it is money that could be better spent improving access and patient care. MCOs cost us money and create obstacles to care. Whereas fee-for-service models incentivize excess visits and procedures, the Medicaid managed care model incentivizes withholding of care and services, especially when there is a profit motive involved. This bill is only asking for an audit to determine if the millions of dollars is well spent so that the state can make an informed decision about how to move forward. Since the MCO contract is up for renewal in 2022, I can't imagine that that is asking too much, and I urge you to pass this bill.
Any questions for this call? Thank you for calling in.
Thank you.
Yep. Next, I believe we have on the line Linda Ujafuza. Councilwoman.
Yes, hello, Senator. Thank you. My name's Linda Ujivuza. I'm co-chair of the Rhode Island Healthcare Access and Affordability Partnership, an affiliate of Physicians for a National Health Program. Thank you, Senators, for hearing my testimony. I hope I am singing to the choir because I believe the majority of people on this committee are co-sponsors. Thank you, Senators Calkin, Valverde, DeMario, Miller, and Bell. Prior to 1994, Rhode Island managed its own Medicaid programs, reimbursing health care providers directly, and now multiple private health insurance companies have inserted themselves as middlemen in this system. And about 90% of all Rhode Island Medicaid recipients, that's over 250,000 Rhode Islanders, are now having their health care managed by these middlemen. And if you look at the reports of the Rhode Island Auditor General since 2009, you will see that each and every year he has basically pointed out that they are very, very they are not audited properly, and has recommended that someone do audit them. And if you were a private person running a $1.7 billion per year program and you were ignoring the auditor's warnings for over a decade, you'd have been fired. And perhaps that has happened because we have new leadership on JCLS. So I am asking you to pass this bill to make sure that we do a simple, prudent fiscal oversight of a $1.7 billion project. And I just want to dispel a couple myths. MCOs are not driving savings of Medicaid. EOHHS has actually stated that the real savings came from increasing the number of non-disabled children and adults who have comparatively low costs, as well as cuts Governor Raimondo made in reimbursement rates, so cuts to hospital reimbursement as well as nursing home reimbursement. Also, I'll just say, Senators, it's urgent that you act on this, or I believe it's Senate Bill 49, which is just the audit now, because they are already in the process of doing a RFP, a request for proposals, for the April 2022 5-year contract renewal with MCOs. So this is the time we have to do this audit to check on them and see if we can have the hundreds of millions of dollars of savings that Connecticut has. And I will send you more detailed supporting evidence. And I thank you, and I'll just say this. I've heard conservative watchdogs say that we must fear nameless, faceless bureaucrats, but that's what we have here in the form of corporate MCOs dictating health care to 1/4 of our state. Please pass this bill out of committee. It was introduced as just a study since 2019. So I appreciate your time, and I'm happy to take any questions.
Any questions from the committee? Thank you for calling in.
Thank you. Take care. Bye-bye.
The next person I think we're able to connect with for testimony is Meg Lynch. Ms. Lynch?
Yes, hello?
Yes, you're on with the committee. Go ahead with your testimony. Let us know which bill and whether you're involved in an organization you wish to identify.
Okay, thank you so much. My name is Meg Lynch. I'm a citizen of Cranston. I'm testifying on behalf of myself in support of Senate Bill 379. I don't have too much to add to the folks who sort of testified before me, but passing this seems sort of like a no-brainer to me. I sort of see it as a step toward a universal health care program. I think any steps we can take to move forward with that are needed, much needed, and long overdue. I think these care organizations, these managed care organizations, are overpaid. I don't believe that this is an industry that should be commodified. Anything that we can do to make sure, everyone is provided for and getting the care they need without these, sorts of things getting in the way. So, yes, I'm in support of this bill, and that's all. Thank you.
Any questions for Ms. Lynch from the committee? Thank you for calling in.
Yep, thank you. Bye.
Next, I think we will connect with Nicholas Doherty. Mr. Doherty?
Mr. Chairman, how are you?
yeah, please identify whether you represent an organization and which bills you intend to testify on.
Of course. So for the members, my name's Nick Doherty. I'm the Director of Policy at Pharma for the New England region, and I'm based out of Boston. I'm here tonight to testify in opposition to Senate Bill 171. The bill certainly does have a lot of details. There's a lot to unpack, and we did submit a statement to the committee that provides a lot greater detail, and for the sake of time, I'm just going to address a few of the concerns that we do have. Completely understand what the bill is trying to accomplish, which is to spread the cost of certain covered drugs that treat rare diseases across all insurers in Rhode Island. But our concern is that this well-intentioned concept is actually going to have the unintended consequence of limiting access to drugs that treat rare diseases. So which drugs are considered a quote-unquote covered drug is determined by the Secretary of Health and Human Services, and the rate of reimbursement for the covered drug is also determined by the Secretary of Health and Human Services. So we find that this is problematic because the availability of the reinsurance payments may be for some, but not all products that treat a particular rare disease. And that might end up resulting in insurers covering or being more inclined to cover a drug that is eligible for reimbursement from the reinsurance program than one that's not. And that might get in the way of the choice that's being made between the patient and the doctor on the best course of treatment. We're also concerned that the legislation is a price control on the exact types of medicines that need the most research and development investments. So currently, 50% of those affected by rare diseases are children, and 95% of patients living with rare diseases have no FDA-approved treatment options. So for these patients, the sustained research and development investments in the rare disease space are critical to finding new treatments. And we feel there need to be incentives for companies to pursue the rare disease orphan drugs because they take nearly 4 years longer to develop than other non-orphan drug medicines. And the success rate is in the clinical trials is only 6%. And Pharma totally recognizes the access challenges that are faced by patients in Rhode Island that have these serious diseases and the intent behind Senate Bill 171. But this bill will negatively impact innovation, especially in the challenging research areas like rare diseases. And it does raise legal concerns as well by applying price control to patented medicines. The bill raises constitutional concerns under the Supremacy Clause because it would be restricting the goal of the federal patent law, which is to provide pharmaceutical patent holders the exclusivity during the life of the patent to recoup the economic value. And that's particularly important in this rare disease space where it does take 4 years longer to develop those drugs. So very briefly, we do, those are the reasons that we do oppose this legislation and would be happy to take any questions.
Just have a question on the difference between the type of access that you're concerned about with this legislation versus the type of access that is restricted currently by a provider either having this on the list of covered drugs or not.
So I think you might, are you referencing the story that Senator DePalma told with the patient, the young child that was unable to access the drug because of the cost at the start of the hearing?
It is an example.
Okay. So yeah, I was trying to actually track that story down while I was sitting here because I was also curious what happened. And in the context of applying that example to the legislation, right now the patient is not able to access this rare disease drug. The companies that are getting involved in developing rare disease orphan drugs are in it to make sure that if they are successful, that drug is getting to the market. So the question might be, is there an issue with the insurance? Is the insurer, I think Senator Lawson had pointed out sometimes, it's actually more cost efficient to pay for the treatment up front as opposed to treatment over the course of the patient's life. And so the question would become, as this Reinsurance Act is designed, the Secretary of Health and Human Services is making the decision what is a covered drug and what is not a covered drug. If that drug in this example is reimbursed, the insurer would likely be more incentivized to provide coverage for that drug
as opposed to the current situation where there is no incentive and there's no reimbursement. So the patient would, in this example, would still find themselves without access to the drug. And some of the ideas that we had, I know a previous speaker on a different subject matter was discussing alternative payment methods. And for these high-cost prescription drugs, we've seen in the last few years there's value-based contracts where each party, the insurer and the drug manufacturer, are both assuming risk in terms of how the patient will be successful, or how the drug will be successful in treating the patient. And by doing that, we're also allowing these companies to continue to innovate and try to find cures for these rare diseases, where, as I said in the comments, there's a 94% failure rate. So there has to be an incentive to keep pushing forward to find more and more and more cures without capping what that price will be. So I know that was a long-winded answer to your question. I'm not sure if that captured what you were looking for, but that's the concern that we have, that it's almost like a winner, picking winners and losers that would be eligible for the reimbursement program, and don't want to see that happen. We want to make sure that patients are being able to access the drugs. And I know OHIC has done some work at looking into new ways to pay for the delivery of healthcare, and this could be one of them. I'm not as familiar as some of the folks who share in that room, but there are ways to be moving forward with these high-cost drugs that are really changing people's lives that are able to access them, and want to continue to push that forward so there's more and more available treatments for people that suffer from these rare diseases.
Yeah, I'm not going to ask you to answer again or try again, but it's just my observation on this type of legislation is that we have many components of that are a concern for us about forces within the prescription drug phenomena that is unique to United States that drive prices either up or down, and I don't necessarily see this type of legislation being more or less of a concern or encouraged approach than others. It just, there are a lot of factors, and I don't see how this is more or less a concern than others. But I think,
if I may just very quickly, so this is, prior to joining pharma, I had been a staffer in the Massachusetts legislature, and this was an issue that we spent almost 3 years trying to figure out. We modeled it after the car insurance shared risk pool, trying to find a way to spread the risk across everyone. And every time we tried to do it, we ran into, and this was an internal review of how to do this, and there were just so many different problems that got in the way. The Medicaid reimbursed or the rebate rate was different. We were running into issues with the self-insured and the ERISA programs. So there are a lot of different factors in play. And I know I said I'd be brief, but there's just a lot of concerns that we have with this legislation.
Right. And I don't mean to engage anymore. You guys are really good at submitting written testimony. I'll just leave with, it's always interesting to find another legislator or former legislator who I know a few who transition into lobbying, and sometimes for those who may have contributed to a problem that they're now trying to solve. But it's an interesting dynamic that will keep going on. Thank you for calling. The questions. Senator Calkin does have a question.
Mr. Chair. So my question is, do you know if any of the manufacturers that you represent are receiving federal tax dollars for research and development of these drugs?
I can't speak to the specifics of, we very much stay high level so that we don't run into antitrust issues. But I know that question has come up before. The pharmaceutical manufacturers that are members of pharma, they do spend on average nearly 3 times more on research than the NIH every year. And so it is true the government does fund some basic research, and but so do the pharmaceutical manufacturers, and that does lay the groundwork for the development in these new treatments. So.
Okay, and then maybe you could also answer, if you know, what is the comparable price for these drugs in, say, Canada, or percentage-wise?
So that's another great question. So we've run into access questions. So new drugs, typically in Canada, the number off the top of my head is usually around 59%. So some of these new cutting-edge rare disease orphan drugs may not even be available in Canada. So it's hard to make that comparison.
Okay, thank you. I appreciate your responses.
Yep. Any other questions from the committee? Thank you for calling in.
Thank you.
Yep. Next person who wishes to testify, I think that we're going to connect with, is Miguel Sanchez. Mr. Sanchez?
Hello?
Mr. Sanchez, go right ahead. Just let us know which bill you intend to testify on before you start.
Senate Bill 379.
Go right ahead.
Thank you. Hi, good evening, committee members. My name is Miguel Sanchez. I'm here as a Providence resident to testify in support of Senate Bill 379. First, I would like to thank all of the senators who sponsored this important piece of legislation. Currently, the Medicaid budget is about $2.6 billion, and of that, $1.7 billion of it goes to MCOs. The MCOs have been able to justify this expense by saying that they are saving us money. However, a report from 2015 from the state auditor general showed us that the MCOs were overpaid by more than $200 million. The state continues to promote the idea that MCOs are cost-effective and provide high-quality care, but really they are just ways for companies like Blue Cross Blue Shield, United, and Tufts to make tons of money, especially during the pandemic. We need to hold these companies accountable. What we really need is Medicare for all, but we can have that conversation another day. Thank you for your time, committee members.
Any questions for Mr. Sanchez? Thank you. Mr. Benedict?
Yes.
You're on with the committee. Please go ahead and identify if you're speaking on behalf of an entity and which bill you wish to testify on.
Sure. I am testifying in support of Bill 495 and speaking on behalf of an organization. My name is Noah Benedict. I am the CEO of Rhode Island Primary Care Physicians Corporation. It's Rhode Island's largest independent practice association. We represent about 177 primary care providers and deliver care to over 120,000 Rhode Islanders. I want to thank Senators Miller, Golden, and DeMario for introducing Bill 495, as well as giving me the opportunity to speak tonight. We're here because current care's opt-in model has not driven the adoption we had originally envisioned. Having only half of the population participating really limits the effectiveness of the tool. This is a missed opportunity for providers delivering care, the patients receiving services, as well as the many quality improvement organizations charged with managing population health, such as mine. We are a huge advocate of adopting the opt-out model for our health information exchange. If this proposed legislation passes, current care could be one of the most impactful tools to help improve our ability to deliver higher quality, more cost-effective health care. I'm sure you've heard the stories about the advantages an opt-out model would have afforded us through this pandemic. Everyone from hospitals to clinicians to the State Department of Health would have been able to rely on a system that could receive information about COVID tests, diagnoses, vaccines from every Rhode Islander. Unfortunately, having half the population on our HIE deemed current care an incomplete data set, and it was not nearly as effective as it could have been at one of our most vulnerable times. Having clinical data available for almost all Rhode Islanders would motivate clinicians to utilize the tool because there's a high likelihood of finding a patient record. Clinicians in their organizations would create crucial workflows that rely on this information to improve patient care. It would save clinical teams time from searching for patient information. It would reduce redundancies as well as decrease medical and medication errors. We also have some really ambitious healthcare goals here in our state, most focusing on improving quality, safety, equity, and costs related to our care delivery system. Some examples are the Rhode Island Foundation's Health in Rhode Island, the Long-Term Vision, Healthy Lives Initiative, the Office of the Healthcare Insurance Commissioners, the Healthcare Cost Trends Project and Affordability Standards, Health and Human Services Accountable Entity Program, and the Rhode Island Department of Health, Health Equity Zone Initiatives, and associated health equity measures. These are just a few of the agencies and associated initiatives designed to drive Rhode Island towards meeting its healthcare system goals. I only mention this because there would be no better tool to help the state reach its population health objectives than a fully operational health information exchange. Having half the population participating is simply just not enough. At this point, the positive impact this would have on quality, safety, equity, and costs is really immeasurable. Lastly, listening tonight, I understand confidentiality is a big concern, as it should be. And I just want to reiterate what some of the previous people had testified again about, which is RIQI in current care follow HIPAA laws. The strict laws, and they are adhered to. And our data is never released, except if it's allowed by law. So I would ask that you please pass this important legislation, give the Rhode Island Quality Institute the ability to actualize the potential of this powerful tool for the benefit of all Rhode Islanders. I really want to thank you again, Mr. Chairman, and the rest of the committee for this opportunity to testify.
So, Mr. Benedict, I just wanted to, since we started talking about this bill in committee tonight, it has been discussed whether law enforcement is involved or would be involved, and I've been passed a note by staff that law enforcement is not currently part of current care. And I don't know if you can confirm that or not, but it has been confirmed by our staff.
I could not confirm that. You would have to ask Dr. Sarkar.
We will. Okay. Any other questions? Thank you for calling in.
Thank you.
Next, we're going to try to connect with Pat Quinlan. Mr. Quinlan?
Good evening, Chair Miller.
Thank you for waiting to call in. Just identify what entities you might be representing and which bills or bill you're testifying on.
Yes, I represent the Rhode Island Radiological Society, and I'm testifying in favor of Senate Bill 651. I would just like to say I've been listening to this committee for a few minutes, or actually a few hours, and I think committee members are probably entitled to credit for a seminar in healthcare policy after one of these hearings. So I appreciate all the time and energy you put into this. This bill is a pretty simple bill. The current law requires that mammograms be sent directly to, results of mammograms or cancer testings must be sent directly to the patient. This is a very simple change in the language, and it basically changes it to ensure that the screening results are sent directly to the patient by mail, electronically, or otherwise in a timely manner. So it merely cleans up an issue basically when this law was written several years ago. And to quote a word that we all learned today, at least some of us did, devices, communication devices monotonically increase the options. So we ask that you look upon this bill and vote upon it favorably. We thank our sponsors. And if you can get this bill, we're trying to conform the language of a parallel House bill that Representative or Chairman Solomon put in. And so we would like to hopefully agree on this language, and we know of no one who has opposed this issue. So it's merely a cleanup to make sure that the results are being sent to patients quickly, faster, cheaper, and in a way that essentially allows the patient to either go to the portal or receive them by email. It's a bill to essentially speed up the transmission of critical results of breast cancer examinations. So I'd be happy to answer any questions the committee might have.
Any questions for the committee for Mr. Quinlan? Thank you for calling in.
Thank you, Chair.
I believe we have Rick McAuliffe on the line.
That is correct.
Just go ahead and identify your affiliation and which bill you wish to testify on.
Yes, and I'm testifying in opposition of Senator Oyer's bill regarding the lab technician licensing. I represent Eastside Clinical Laboratory, where we employ 300 people in the state of Rhode Island. We are state licensed, and we have concerns with this bill. And I'll speak very quickly because I know you have a busy agenda. Just some background. In 2000, the state decided to license rather than certify all the lab technicians, and that went on for about 17 years. During that 17 years, there was one complaint in 17 years by the Department of Health, and that was a HIPAA violation, not doing with anything with lab technicians and so forth. In 2017, Governor Raimondo put in her budget, and everybody in the Senate and House voted for her article and the budget. In 2017, that actually repealed the ability that you had to have your lab technicians licensed rather than certified. That passed 5 years ago, and there seems to be no real reason to bring it back. Everybody in the industry seemed very happy with it. Both Massachusetts and Connecticut do not have this requirement. Matter of fact, most states in the country don't have it. And I will just say lastly that all labs in Rhode Island are licensed. Technicians already have to be mandated by CMS and registered and accredited with the Clinical Laboratory Improvement Act, which is CLIA, and College of American Pathologists also do the same thing. So these standards are actually higher than some of them in this bill, and some of them are actually copied from the bill. So we have that. And the last thing I would say, and the reason we have some concern with it as well, is there is an exemption for the state lab, and I guess my question is, why does the state lab get to exempt themselves from this bill, but Eastside Clinical Laboratory, which does almost all the testing for the nursing homes in the state, both for-profit and non-profit, have done the testing for COVID and have done other collections for the state, have to comply with this, and yet the state lab is exempt. We think it's not necessary. It's not done in other states, like I said, in our area, and while it's well-intended, I think the certification that these technicians have does that. The labs they work for have to be licensed, and like I said, they go through CLIA and American Pathologist licensing already, and obviously the Department of Health continues to inspect them. So it's for those reasons that we're opposed to the legislation.
Any questions
Maybe
for
I have to
Mr.
take any
McAuliffe?
questions.
I think there are no questions from the committee. I want to thank you for calling in.
Thank you, Mr. Chairman. Have a nice night. Thank you. Okay, bye.
I think next on the trying to call in will be that we will connect with is Sammy MK. I'm sorry I forgot didn't pronounce your name right. Sam MK?
It's Sammy Arki.
Okay, sorry about that. Go right ahead.
Okay. Yeah, hi. My name is Sammy. I am a constituent of Senator Gail Golden's district. I'm here to testify in support of Senate Bill 379. I did want to sort of say that the numbers around 25% of Rhode Islanders are covered by Medicaid, and a lot of those folks are kids. So this is a really important program, and that's why I'm here tonight, because of how important this is to so many people. And I also know that 90% of Medicaid, about 90%, is run by private MCOs right now, managed care organizations, and they're making a lot of money, especially during COVID. And the reason why I think this audit bill is necessary is because why wouldn't you want to know kind of where public tax dollars are being spent and how efficient that is compared to other programs? And this is after the 2015 report from the state's Auditor General showed that we're paying more than $200 million every single year in terms of overpaying these MCOs for the actual care they're giving. So it makes total sense. It saves a lot of money. That's money we could put into the literal crumbling school systems we have, et cetera, et cetera. And, that was from 2015. I can't imagine what it is right now in 2021, and especially during this pandemic. So if we see that the public option saves us money and provides better quality care, then it's a no-brainer. So I really want to support. I urge every single one of the senators on this committee to support Bill 379 because it would audit, and then it would deprivatize those that are deemed more expensive. So yeah, I would encourage you to vote that we don't continue getting ripped off by these companies, because that's what's been happening. Thank you so much. I yield my time.
Any questions for Sammy? Thank you for calling in.
Thank you so much. Have a great night.
Next, I believe we have on the line is Sean Donahue from Blue Cross Blue Shield of Rhode Island. Sean?
Yes, Mr. Chairman. Sean Donahue here.
Go right ahead and let us know which bill you intend to testify on.
Very well, sir. It's bill number 171, and and this is Sean Donahue on behalf of Blue Cross Blue Shield of Rhode Island. I would like to publicly and strenuously thank Senator DePalma for his moving presentation on this bill. His introduction of Aya and the struggles that she's going through are very moving, and that's the reason behind this bill. And I fully believe that this is the mechanism that will provide the mechanism so that when the next incidence of a rare disease child in this state is manifest, that the funding mechanism is available to make sure that that child has access to the drug. In my written testimony, I included a story of Malachi, who was another child with SMA, but in my written testimony, I go into his story, and I also have links to his story, and I won't belabor the point with the length of the hour, but I do want to point out that thanks to incredible advancements in genetic research, there are other stories like Malachi's and Aya's on the horizon. Approximately 2 million people have inherited retinal disease, which is due to a genetic malformation or genetic defect. FDA has approved a drug that would replace that genetic material and preserve the sight of folks that would otherwise go blind. The cost of that therapy is $850,000. And researchers at MIT and Harvard project that there could be as many as 60 new genetic-based therapies for rare conditions considered by the FDA approval for their orphan drug program. And to answer Senator Wilkins' question, drug companies get up to they get to write up to 50% of their research and development costs for drugs that are in the orphan program. And orphan definition is any disease treatment that impacts less than 200,000 Americans in the population. So it's not a 1 in a million. It's about 14 per million that our actuaries think we'll start to see starting in 2022. And Senator DePalma and Senator Miller's legislation would establish a funding mechanism to ensure kids like Malachi have better access to these life-saving proposals. The young girl that he mentioned actually is a citizen of Denmark, and Denmark hadn't approved the drug, and that's why they had to go to a GoFundMe scenario. Malachi actually is in this country. And what we want to make sure is that the next Malachi that turns up in Rhode Island has access to these drugs, and that there isn't a problem with securing funding for it. I do want to mention and react to two comments made by the representative from Pharma. Yes, this is a unique proposal, but we were in the leading edge of the vaccine program that has been so successful in this state. We have some of the highest vaccination rates in the country, and that funding mechanism is available for the state to purchase these drugs at prices, frankly, we as a private entity could not purchase them at that rate. So it is about the price at which the drug is acquired. Pharma would much rather have us have to come to them and pay a price much higher than what the state could secure for these life-saving drugs. Lastly, I'd like to, on behalf of Blue Cross, express our sincere appreciation to the Chairman DePalma and Chairman Miller for sponsoring this legislation. There isn't an if these high claims are going to be faced by municipalities in the state of Rhode Island and, frankly, drug health plans like ours. But every actuary and analysis of these new genetic treatments, these miracles, are going to be available in approaching the marketplace in numbers that are going to have an impact on the affordability of health insurance and health care in the state. And we need to be able to be ready for that. And that is just an inevitability. The science has progressed to such a state that it's just a matter of time before we are overwhelmed by the cost of these drugs unless we put in a program like Senator DePalma has shown in his legislation. I'd be happy to answer any questions.
Any questions for Mr. Donahue from the committee? Thank you for calling in. Sorry it's so long down the list, but
perfectly fine.
Thank you.
Thank you.
Next, I believe we're continuing to go back to calls where we didn't get an answer or weren't able to connect. Therefore, we're now have Leo Schumacher on the phone.
Yeah, hi, thank you so much for hearing my testimony.
Just let us know which bill you're testifying on and whether you also represent an entity besides yourself.
Okay, I don't have the form or the computer right in front of me, so I don't know the number, but it's the MCO bill, and I support it to audit and replace the MCOs.
Yep.
So my name is Leah Schumacher. I'm a resident of Providence, and I support the bill. I know you have heard a lot of testimony this evening, as well as other evenings in the past couple of weeks about healthcare in Rhode Island. And I hope, or at least I think or hope we can all agree at this point that we haven't yet mastered healthcare. I know listening to testimony, there's so many powerful stories about how people cannot get the care they need. You've heard lots of data about how the U.S. and by default Rhode Island, you know, we haven't yet mastered this. So many other countries have better access and health outcomes, and certainly we are not the most efficient for healthcare in terms of finances. I know MCOs are currently part of how the system is set up, and I really just think we can build a better system. Just because it's the system right now does not mean it has to continue to be that way, or that by default that's the way it has to work. I think when we look to other states, including Connecticut, and at historical data in Rhode Island about MCOs, there's sort of this sneaking or perhaps gnawing suspicion that this is not the most efficient way to run healthcare. And it's not just, money that's being lost, taxpayer dollars, but people's lives are really being affected negatively. So I just encourage you as a taxpayer, as a constituent, to really seriously consider this bill as well as the others that have been held for further study, and to really seriously commit to creating a better system in our state for healthcare. Thank you so much.
Any questions for Leah from the committee? Thank you for calling in.
Thank you.
I believe we now have on the line Susan Corcoran.
Yes, that's right.
Go right ahead. Let us know what entity you may be speaking on behalf of and which bill you're also discussing.
I'm discussing the bill, I believe it's number 495, to make current care opt out. And I'm speaking on behalf of myself. I'm a registered nurse. I'm the director of nurses at a community mental health center. And as you probably know, the community mental health centers in Rhode Island are tasked with the role of integrated health home for people with severe and persistent mental illnesses who receive some of our services. And current care has been invaluable for us in improving the integration of medical and psychiatric care for our patients. We work with people who tend to utilize emergency rooms for their care and or urgent care settings. And our job is to help them get preventive care that's less expensive to the state that pays through Medicaid. So we utilize current care in many of the same ways previous testimony has reflected. We are able to look at medications that people are on and make sure that we're not ordering something that conflicts with their medications. We're able to confirm that they're actually filling their medications at pharmacies. We're able to look at lab work that tells us whether a medication we're prescribing causes a problem for the person or whether they have a medical condition that we're not aware of that we can help them get better care for. And what I have found as a healthcare consumer in Rhode Island is that people are not often offered the opportunity to enroll in the health information exchange. Some settings do better than others, but I know that there's been some discussion about people refusing to enroll, but I find the problem tends to be more that they're never offered the opportunity. We do offer it to anyone who comes into our services, and we find that we have a pretty high rate of enrollment, even though these are people who may have co-occurring disorders that they haven't previously been comfortable with information being shared. But they know that we're trying to help get them the kind of care that they need. It improves our patient education efforts. It improves our team communications, both amongst ourselves in multidisciplinary mental health services teams, but also with providers in the community. And so my feeling is that the more people we're able to serve by having their healthcare information be thorough and correct, the better off we'll all be. Any questions for me?
I don't think so. Are there questions from the committee? I just have one question based on your focusing on mental health patients. Any indication that you know of any violation of HIPAA or breach of data?
No, at this point, and someone from current care or from RIQI can possibly, there's a lot of feedback, hearing a lot of feedback on the line.
We can hear you anyway, so.
Okay, all right, I'll just keep talking and I hope you can hear me. Most mental health information actually doesn't go into current care. We may be able to see medications that people have filled. We may be able to see that they have been to an emergency room in a mental health crisis, but our notes from our facility at this point do not go into current care. It's more of a medical information exchange that really improves our ability to help them get better medical care, which is our job, in addition to provide, because we have these sort of close relationships with people who may have difficulty trusting care providers, and we spend a lot of time developing those relationships. They may be more willing to work with us to get other kinds of care. And so for us to have their medical information correct and accessible helps us do that with them. But for example, Butler Hospital doesn't give information into current care, and things like therapy notes and appointment notes don't end up in current care. Only our medication prescribing and some of the lab work that we prescribe is visible in current care. And it's all protected by the 42 CFR HIPAA stuff.
I think Senator Bell also wants to ask you a question.
Okay, thank you.
Yes, thank you so much, Mr. Chairman, and thank you for your testimony. Just following up on the chairman's question, in your experience, can any data involving illicit drug use be entered into the current care system if patients report to their providers that they, for medical reasons, that they have engaged in illicit drug use? Can that information be entered into the system?
There's no, to my knowledge, there is no place where that information that is gleaned in an interview would be found in current care. However, some lab results, top screens, are available from emergency room visits and hospital visits in current care. So we're able to, to see if someone has gone in with an overdose or has something in their system that some of which may be prescribed, some of which may not be. So that's the only place where that information is found that I know of.
Thank you so much.
You're welcome. Thanks for your question.
Thank you. Any other questions? Thank you very much for calling in. And you were perfectly clear. You're perfectly clear on this end, no matter how it sounded on your end.
All right. Thank you.
Yep. Next person we should be connecting with is Thomas Douglas. Mr. Douglas?
Yes, hello.
Go right ahead. You're on with the committee. Just let us know if you represent an entity and which bill you're testifying on.
Thank you. So my name is Tom Douglas. I am a director of finance at the Providence Community Health Centers. I'm testifying in support of 2021-S0495. I know that a number of my colleagues, clinicians, doctors, and medical officers at PCHC sent letters in support of this legislation as well. I believe really strongly in the potential of current care to improve clinical quality in Rhode Island. It's very important for doctors to communicate with one another to take care of us. And today, communication that many of us assume is taking place behind the scenes isn't, because each Rhode Islander has to go in and turn it on. And so our clinicians loudly support this bill to enable much improved medical care in Rhode Island. I loudly support this bill as well for the same reason and would encourage you to please pass this legislation. Thank you very much for your time.
Any questions for Mr. Douglas? Thank you for calling in and waiting so long.
Thank you.
I think next we will have Thomas Sicoscio. Mr. Sicoscio?
Hi, this is him.
You're on with the committee to testify. Just let us know whether you're speaking on behalf of yourself, an entity, and which piece of legislation.
Hi, yep, my name is Thomas Sicoscio. I am representing myself, and I am testifying in support of Senate Bill Senate Bill 379.
Go right ahead.
Thank you. I would first like to thank my Senator Janine Calkin. I'm a resident of Warwick, Rhode Island. Thank you for your support on this bill. I'm sorry, I'm getting a lot of feedback. Is that?
If you have a feed on, it might be based on that feed, so I would turn the feed on.
No, it's echoing from the phone, not the computer.
Oh, okay. I'm not sure we can correct that, but we can hear you perfectly clear through here.
Okay, all right. Sorry, it was tripping me up a little bit. Want to make sure. All right, I'll keep going. I'll be quick.
you guys have heard enough expert testimonies from doctors and healthcare professionals and stuff like that. But just over the course of this hearing, I've learned that private Medicare is bloated, it is inefficient, it is expensive, misleading to the public, and undemocratic. Rationing care for low-income people to line pockets of CEOs, lobbyists, and especially politicians, in my opinion, is flat-out cruel. Rhode Islanders and Rhode Island itself needs to set its priorities straight and make Medicaid work for the people who really need it. The working people in Rhode Island want you to support this bill and move it out of committee. Thank you very much, and have a good night.
Any questions for Thomas? If not, thank you very much for calling in.
Mr. Chair?
Senator Calkin might have a question for you. Sorry about that.
That's okay. Thank you.
Yep.
Mr. Chair. I just wanted to thank you again, Mr. Secretary, for coming out and testifying. I know you testified during the last round, and I believe you were testifying in the House too. So I want to just say I appreciate your support of these bills, and wanted to thank you for coming out and testifying.
Yeah, no problem. You know, you guys are doing it in there, and I'll do it out here. Thank you very much.
So I believe that's our last call, but we do have a little bit of business, and before we get to that business, I want to make it very clear that I totally understand, and much of the staff also does, and many of the senators on the committee and elsewhere, that some of this legislation is very timely, and we are very interested in passing this as soon as possible, hopefully before our April break, out of committee and eventually to the floor. But there is a substantial amount of both written testimony and the testimony we've heard on the phone that we do have to review before we further consider this legislation. And I want to give one example. You know, we had the ACLU on the legislation that I actually thought we could do sooner rather than later on Senator Goodwin's sunset removal. But we need to take a careful look at the ACLU's proposed amendment on that. And another example is 379, which, you know, I'm very supportive of the concept of, and one of the things that is concerning in it is that did we identify the right person to make this audit? Does the Auditor General have the resources and the expertise to make this audit? And so I think we should take the time that it would take to make this as effective as possible and potentially identify another more appropriate entity that could more thoroughly and with more expertise audit the MCOs, because it might be inappropriate and not lead us in the direction that the legislation intended if unqualified and office with not enough resources to do for it. So I would like the committee to take the time to potentially identify alternatives that would be more qualified, as an example. And on Senator Oyer's Bill 169 also, I think we need to look carefully. It was legislation that we have heard before, and the clash between certification and licensing may be a concern that we have to look at as examples of why I will make the motion to hold for further study Senate Bill 162, 169, 171, 303, 379, 495, 650, 651, 711, and 713.
Second.
Seconded by Senator Valverde.
Could we divide that motion?
The motion's been made.
Right, and I'm requesting that the motion be divided.
To what?
So I would like to separate out 171 and 379.
Okay. So I'll amend the motion to 62, 169, 303, 495, 650, 651, 711, and 713. Is there a second?
Second.
Second.
The clerk?
Chairman Miller.
Yes.
Senator Valverde.
Yes.
Senator Lawson.
Yes.
Senator Bell.
Yes.
Senator Calkin.
Yes.
Senator DeMario. Senator DeMario.
Yes.
And Senator Golden.
Yes.
Chairman, we have 7 in the affirmative, 0 in the negative.
Thank you. Make a motion to hold 171 and 379. Is there a second?
Second.
The clerk? Yes.
Senator Valverde.
Yes.
Senator Lawson.
Yes.
Senator Bell.
No.
Senator Calkin.
Yes.
Senator DeMario.
Yes.
Senator Golden.
Yes.
Chairman, we have 6 in the affirmative, 1 in the negative.
Thank you. Is there a motion to adjourn?
So moved.
All those in favor?
Aye.
Aye.
I want to again thank Senator Valverde for helping me get through another long evening, and an evening where I was interested in being in another committee for a while. Good night and thank you all.
Good night.